Hello professionals, this is Dr. Saad, and as you know we are recording series of lectures for pharmacists who are going to appear for international equivalencies exam. And for new viewers it is requested to go and watch our previous video so that you can acquainted of our strategy for the preparation. So let's start the remaining part of our autonomic nervous system. Today, first point, we will again discuss about the organophosphate poisoning as we discussed in previous video, but here I would like to mention something more. But before I start this, I would like to tell you that please revise physiology, because physiology of autonomic nervous system will always help you for the understanding of our strategy for the management of our body at various conditions and deployment of drugs. So as I told you that neurotransmitter, either it is adrenergic or cholinergic, anything blocks its abnormally blocks its release or abnormally increase its release, it will act as a poisonous effect of the body. Like as you know, botulinum toxin, it abnormally blocks the neurotransmitter release. It is also cause toxicity. Similarly, organophosphorus poisoning, it inhibits the acetylcholine esterase, which actually control the excessive amount of acetylcholine at the synaptic synapse and split them into the acetate and choline. But once this, or because of the organophosphate, phosphorus drugs, that is the parathione and malathion, these are the example of these drugs, and it is actually used as an insecticide. But if any human mistakenly exposed to this drug, then it it cause a poisonous effect in them, and excess amount of acetylcholine generates a lot of abnormal response because of excess amount of acetylcholine available at the neurotransmitter. So it is managed by using anticholinergic drug, that is the prolidoxim. It is an antidote of this organophosphorus poisoning, but it is a common sense that if acetylcholine released excessively, then anticholinergic drug will act as an antidote. So I just mentioned its example for your revision. Similarly, I want to clump another concept with this, that okay, we'll discuss next point later on. Number two is, as I told you yesterday, that parasympathomimetics, as we discussed yesterday about the M3 receptor in eye, which act about its meiotic agents and mydriotic agents. And this is one of the nice term which can be asked in an exam, that parasympathomimetics uh, are those drugs like pilocarpine, like carbachol, like phospholine. Its example is I forget its example, as you just revise my previous video. It's actually acetylcholine esterase. These all increase the availability or increase the level of acetylcholine at M3 receptor, which causes meiosis, and it is helpful for the open angle glaucoma. So let's move on our point number three, that is about the sympatholytic long-term use causes hypertension. So it is very common, like it's just a technical question, like sympatholytic, as you know that sympatholytics are those drugs. There's two division of ANS, as I told you previous in physiology: parasympathetic and sympathetic. Parasympathetic always has different neurotransmitter, and sympathetic have different neurotransmitter. Its neurotransmitter known as adrenergic. And as I told you, the sympatholytics mean to say anti-adrenergic. Like it is, he is talking about the alpha blocker, beta blocker. If you use excessively, it will, for long term it will cause hypertension. Definitely it will cause, because we use this series of drug for the management of hypertension. But there are certain conditions. For example, alpha blocker also used for the BPH. For example, if you are using alpha blocker for BPH for long term use, then you must need to monitor the blood pressure of that patient, because maybe in that case it can cause hypertension. It can be little bit problematic for him. Okay, fine. Next, let's move at our point number four. That is the nylidrine. This is beta receptor, beta adrenergic agonist. This just for an example. It's a beta adrenergic agonist, nylidrine, and it causes vascular dilation at the skeletal muscle. Very common point, as I told you, that beta 1 receptor is positioned at the heart, which will play a key role in increasing cardiac output. Beta 2 receptors are in the lungs as well as skeletal muscle. And yesterday we also discussed this point when slow infusion of adrenaline actually play a key role for the increasing cardiac output, but it doesn't cause diastolic hypertension. So it is also talking about this point. This is another example of beta 2 beta adrenergic agonist, because it binds at the receptor of beta 2 at a skeletal muscle and causes vasodilation. So it will actually play a key role in the management of diastolic blood pressure. Our next point is the non-epinephrine. Point number 5, that is the non-epinephrine. Where is its position? Like, simply, you know it very well that non-epinephrine in a sympathetic nerve division, it is positioned at post-ganglionic sympathetic receptors. Once you go and review the physiology and anatomy of sympathetic nerve division, like after ganglia, at the point of receptor neurotransmitter, which is basically used for transmission of signaling, is the norepinephrine and presynaptic receptor of nerve ending. So at this point, norepinephrine is used is used for the chemical signaling. Let's move for the point number 6. This point number 6 is linked with the point number 1. That is relevant to as I talk about the organophosphate poisoning. And right now, I would like to review about the peripheral nervous system. There was its two division. That one was ANS and the second was the somatic nerve division. Somatic nerve division actually controls the skeletal muscle through acetylcholine, which binds to the nicotinic receptor of skeletal muscle. Like, the main concept will remain same. For example, if anything like increases acetylcholine at this receptor, it will actually increase its response. And similarly, if anything inhibits this receptor or inhibits the release of acetylcholine at the nicotinic receptor, it will cause blockage of activity of skeletal muscle. So this is something which happens like nicotinic receptor. If nicotinic receptor is blocked due to uh, a lower level of acetylcholine, just leave on this concept. Just keep in your mind that if nicotine receptor doesn't receive enough acetylcholine, it will lead the body toward the paralysis or fatigue or exertion of muscles. And what could be the reason? Number one reason could be maybe because of botulinum toxin. Acetylcholine can't reach as the neuromuscular junction, or maybe due to autoimmune disease, nicotinic receptor is being destroyed. In both conditions, the situation will remain same. Patient will face paralysis of skeletal muscle, fatigue. So this situation can be very serious, and this condition is defined as myasthenia gravis. This is the mechanism of action of myasthenia gravis, where nicotinic receptor either destroyed by the autoimmune disease or in a lower level of acetylcholine. It can't work properly, so myasthenia gravis patient will face paralysis of muscles and fatigue and exertion. These are the signs. For example, if myasthenia gravis is because of the lower level of acetylcholine, then we use a very well-known drug, that is neostigmine and pyridostigmine. It actually inhibits the acetylcholine esterase, which increase the level of acetylcholine. Here we are using this enzyme for our advantage by increasing the level. So it will, in this way, we manage the patient. And on the other hand, if the situation is because of the nicotinic receptor destruction, then we use a skeletal muscle relaxant. Its example is meprobamate. It is a tranquilizer, skeletal muscle relaxant. When we will discuss the system of central nervous system, there we will discuss this drug in a detail. But just for remember, just for a flash, you will just keep in your mind that meprobamate is a drug. It's a tranquilizer used as a skeletal muscle relaxant. It can be used in this situation. Next point number 7, that is about MAO monoamine oxidase. No, sorry, methylxanthine mode of action. It is a very common drug. It's specifically, its example is theophylline, and its mode of action is actually increase the cyclic AMP, which relaxes the bronchial smooth muscle and pulmonary blood supply. This is basically used for the respiratory conditions. It's one of the well functional clinically used drug, and it's as I told you, its name is the theophylline. So this was about that point because it's about mode of action is only increase cyclic AMP. Point number 8, it's about the again about the this is the same point which we have already discussed, is the organophosphorus poisoning. Acts as an its clinical use is for the crops as an insecticides. Point number 9, it's our second last point. It is about the beta agonist mode of action. Beta agonist actually activates the adenyl cyclase, which increases cyclic AMP. Beta agonists, as you know, that adrenergic agonist beta, there are beta receptor beta, and drugs which acts at the receptor through the mode through this mode of action. It activates adenyl cyclase, which increases cyclic AMP level. So this is one of the point which can be asked in exam. So I think video is going to be very long, so I should keep it very short right now. We will discuss the remaining point in next video. Just for a last point which I want to tell you here is the that is the L isomer is more potent than D isomer. This is an you have to go for the medicinal chemistry of drug. For example, if in adrenergic drug L isomer is 20 times more potent than D isomer. Similarly, in anticholinergic drug, that example is the atropine. Here L isomer is 100 times more potent than D isomer. Okay, professionals, I will discuss the remaining point in next video because I don't want a lengthy video to make you to put you in a fatigue. See you and stay tuned. And if you feel that our this effort is suitable for you, then please subscribe our channel. Your subscription play a key role for our appreciation.